Good evening and welcome. I am Meeta Roy. And November is Lung Cancer Awareness Month. A time to raise awareness about the leading causes of cancer deaths around the world. Lung cancer causes about 1.8 million deaths each year. More than breast, colon and prostate cancer combined. It is the second most common cancer with 2.2 million new cases diagnosed every year. Unfortunately, early detection is still a challenge as only 5% of people who should get checked actually do. This segment is brought to you by Shastha Sahay in association with the Lung Cancer Study Group, Kolkata. Today, we'll be talking to an expert about the importance of awareness and early detection. Let's get started.
Hello, I am Dr. Anjan Das, Professor of Pathology, NRS Medical College Hospital, Kolkata. Today I will discuss the investigation of lung tumor. Lung tumor is a burden, in our country it is a burden nowadays because a majority of the patients presented in the late stage of the disease. But investigation, early investigation have an important role for detect earlier and give a therapy to the patient so that they can cure. Now, what are the investigation? Usually we diagnose the lung tumor by cytology and histopathological examination. We get different type of cytological smear. In rural practice, usually we get sputum for malignant cell. It is not good enough because it have a great number of false negativity and it is not specific or sensitive also. That's why nowadays different other cytological smear are examined, like if the lesion is located in centrally, we perform bronchoscopy and bronchoscopy guided brass smear or bronchoscopy guided imprint smear, or we may collect bile fluid for malignant cells. These are the all modalities nowadays we are used in when the lesion is centrally located. On the other hand, if the lesion is peripherally located, in that situation we usually perform CT-guided FNAC or two-cut biopsy for cytology. Now, the bile fluid or brass smear or another entity is there, that is transbronchial needle aspiration cytology, which is also having good cellular aid and which is a good sensitivity and positivity for detection of the lung tumor. Now, in the biopsy, what happened? Sometimes there are different, particularly in our country, tuberculosis is a major problem, and sometimes TB lesions radiologically mimicking malignancy. So FNAC here have a great role to exclude the tuberculosis by the investigation of cytology, by the use of CBNAT, by the use of ZN stain, we can exclude the malignant lesion. We can exclude the tuberculosis. Now, another cytology is the pleural fluid, where pleural fluid usually some patients presented with late stage lung cancer along with pleural effusion. In that situation, we collect easily the pleural fluid for the malignant cells, and this fluid can be utilized for cell block, and this cell block is again used for the immunohistochemistry to exact categorization of lung cancer. Now come to the biopsy examination. Usually we get lung biopsy by bronchoscopic biopsy, or say peripheral located lesion, we can go for two-cut biopsy. Sometimes our CT-based surgeons also prefer to pneumonectomy or lumpectomy by thoracotomy. But all this method, also we get pleural biopsy. When there is a evidence of pleural infiltration, we go for pleural biopsy to detect the malignancy. In all this method, we get the tissue. This tissue is helpful not only for diagnosis or exact categorization of the lung cancer, also It helps in immunohistochemistry. It helps to in molecular. The material can be used for molecular testing, genetic study, genetic mutation, because nowadays different drugs are available by targeting the particular genetic mutation, and also we can predict the prognosis by detecting that particular type of mutation. That's why biopsy examination have a great role for not only diagnosis but also patient prognostication of the patient, or also therapy, to make a therapy protocol. That is about the lung cancer, lung tumor.